Welcome, everyone. My name is Emilia Andersson. I'm a medical affairs employee from Roche Diagnostics, so proud sponsor of these educational sessions. And I hope we saw most of you in the previous session with the background educational overview of the Kappa Lambda dual-ish staining. And today we are connecting just to review the cases and the scores that you have submitted. I really would like to just highlight that CADCAS, they always advertise on LinkedIn that these sessions are happening. So please feel free to share with your colleagues if you think that this is something they would benefit from. It's free to join, as you know, and the more that can listen to it and discuss, the more interesting it is for everyone. And also, you are free to ask questions. Either you raise your hand and you speak up, or you just post it in the chat and we make sure it will be addressed. And with that, welcome, Corrado and Adelina. We look forward to listening to you.
Thank you very much. I'm trying to admit people from the waiting room, but I failed miserably. Just a moment. How do I get the room? Maybe we need to go here. Not really. Okay, so we thought we would be all right without Hannah, but in fact, we failed miserably.
You will have to give her extra bonus and tell her how important she is.
Okay, waiting room. Can you see waiting rooms?
I'm not sure why you have 2 bars, but that's okay.
Yeah, that's okay. More. There must be something in more. Transfer meeting to room. What does it mean? Okay, guys, I am really struggling here. 4 people view. Fantastic. Admit all. Okay, we are in business. Admit all. Fantastic. Excellent. So thank you all very much. We'll keep an eye on people that are joining now and we'll admit them. Thank you very much for joining us. And thank you, Emilia, for continuing to sponsor these educational activities. More people. We had this circulation for a couple of weeks, we have results of these cases. I must say that, like everybody else, I'm kind of learning a little bit on how to interpret these things, and also it would be perhaps a good idea to have perhaps a discussion about why do we use this test and what is the context. So the first case, which I hope you see my screen, I think so, you see here. So the task of this was to try and understand whether the lymphoid infiltrate in these slides had a monotypic expression of kappa or lambda, or it was polytypic. And if it was monotypic, whether it was more kappa or more lambda. And of course, there is always a box for, I have no idea, I don't know, I cannot tell. And down below here, there is what the panel of CADCAS people thought this was. And you can see here, we thought it was a polytypic, no restriction. And most people thought it was polytypic. And we could have a look at the slides.
That's 03.
This one. Fantastic. And these are mostly extra lymph node kind of problems. So this is cutaneous, because I think that one of the great assets of this test is in these odd lymphoid infiltrates that come to the pathologist without much clinical history. It's not the same when you have a patient who is investigated for night sweats, lymphadenopathy, etc., that now we have a biopsy for BCC and then we find something like this, and then most of us say it's probably benign, and some of us feel actually at high power these cells are a bit ugly.
We're not very helped by history when it comes to extra.
Okay, so at low power, this would seem like a nodule, perhaps 2 adjacent nodules with germinal centers, with kind of a mantle, etc. So it looks like a reactive tissue. Of course, there are pitfalls on that. And let's keep an eye on people that arrive late and admit. And at high power, you kind of feel that there is a little bit of erosion of the edges of this germinal center, but there are small lymphoid cells at the periphery, and then you would have seen large blasts and centrocytes as well. Tingible body macrophages, maybe not so much, but there are mitosis, which would be reassuring. And I don't know whether we have immune on these things or we want to show immune.
We could.
We could, because obviously you would have a workout and trying to understand whether, there is high Ki67, whether BCL2 is positive or negative, etc., etc. But maybe also the question would be what's happening in the interfollicular areas, because they're a bit indeterminate. And then you start seeing all kind of things like eosinophils.
We do have,
So you feel
a mix of immune cells in the interfollicular.
Okay, so let's have a look at the only other slides we had, which was the dual-ish. And remember, we had a little bit of kind of on-slide control just to see what things are like.
This is perhaps not the best
the best control we could possibly. Well, it's not the best execution. So here you have a bit of silver precipitation on the squamous epithelium, which obviously is not right. You have very darkly staining cells, which are likely to be plasma cells, and they show the pink or magenta and the black staining. And we were just talking with Adelina just now, how do we remember which one is which? And I remember Anne suggested it's very easy because pink has a K at the end, and pink is for Kappa. And then I said yes, and black has a K at the end, and black is for lambda. But anyway, so I think we need to kind of remember the black. So the way I remember is that lambda is the weak, the less prominent chain, and it has been given the strongest contrast, which is the black contrast, and the silver grains are much more contrasted and better. And the kappa, who is more prevalent, has more abundance, is given the least, the second best stain, which is the magenta stain. Okay, so this is the control, but okay, of course we can stain the plasma cells. Everybody can stain the plasma cell. We discussed it last time, but what we are really, really interested is in the small cells that you see here. And this is something you wouldn't be able to get with the usual in situ hybridization that we used to do before, that these are very low level signals, and you can see these cells have got polytypic. Some of them are magenta, some of them are black. By and large, you remember we discussed the fact that some cells have both. By and large, we don't find cells with both dots. You need to understand that there is some bleaching or some leaking of these signals, but by and large, the signals are very close to the nucleus, which is where you want to see. If we go to the mantle, let's see if I can find a mantle for you. Who knows? Maybe here. Because in the mantle, you should see cells with very little expression, but you can still detect the type of light chains that they express. Okay, so this is our control, not the best slide, but anyway.
We don't have proper follicles there.
Okay, so that's our skin. There is an infiltrate.
Can I just, because it was one of the questions that were submitted, how do we interpret very weak signals? And I think you essentially just discussed that, but just to make the final point, weak signals are indeed included in the assessment.
Yep.
You just need to understand whether you deal with plasma cells or lymphoid cells, or what would your key message be?
Yeah, context is key, I guess. Okay, so when we were doing a little bit of work with Teresa Marafiotti, whom I tried to entice to this presentation, but she wasn't very well a couple of weeks ago, and I think she's quite busy in her job. She's looking for colleagues to join her because they're very stretched at UCL. She was telling me, sometimes this is just a low power impression. Do you see both colors? And that's kind of good. Of course, you need to go at high power. So at the moment, the dark staining cells are heterotypic. There are both. Here they're both. And then it depends very much where the subject of your attention was. And to tell you the truth, I can't really remember this case, whether we thought one or two of these germinal centers were suspect. I can't remember. But then you should zoom in into the area where morphologically you found that there were problems. This is what Emilia was saying, this low-level expression is relevant. In small cells, you have low-level expression. But here you have a germinal center that seems to have both colors expressed. There doesn't seem to be monotony of one color versus the other. And the same perhaps with this other germinal center. But maybe the germinal center was not the problem. Maybe the interfollicular areas were the problems, or the marginal areas were the problems. Not very good scan. Let me find another area.
I don't see, because we see a lot in the germinal centers, but there's a lot of T cell population in the interfollicular. We have a few immunostates as well.
So yes, that's a good point as well. You see, in the interfollicular area, there is no signal because these are not B cell, so there wouldn't be a production of these genes, expression of these genes.
I guess if you were to see a population of, let's say, plasma cell, and you wanted to know whether on morphology that they're B cell or B cell origin, that would be easy to throw Kappa Lambda, but otherwise you need to have a T cell, B cell marker at least.
Indeed, but somebody else here, let's admit. Indeed, but Ade, in reality, we discussed this before. In reality, there are antibodies, there is immunohistochemistry to do this. And while it is really difficult to read on cells that have very low signal, for plasma cells, it's quite easy to read. You remember that we saw those papers, 1974, one of the first immunohistochemical determination with polyclonal antibodies that were very clearly interpretable.
Yeah, but right now I would do, even for plasma cells, I would do this because this is much
because it's nicer. Okay.
Okay. The immuno, sometimes it works so well and the signal is so sharp.
But you see, immuno is $5, €5, £5 a shot. In situ is £100 a shot. So it or 150 is a significant difference. And I think, yes, much as we quite like in situ, maybe it's an overkill when you have a lymphoplasmacytic infiltrate with strong expression. But it's really, really difficult. And in some laboratories, they do Kappa and Lambda by immunohistochemistry really, really well. I agree. Most laboratories, we struggle with that. This tissue here seems to be a tertiary lymphoid structure with reactive germinal centers and interfollicular area. So it's a benign, what people call lymphocytoma cutis, whatever it means. It's just a tertiary lymphoid structure at the moment in the skin, in the subcutaneous tissue. And I think most participants, if we go back to here, participants thought was the same. Some people thought there was a little bit of restriction. The other thing I wanted to say,
Kappa. That's interesting because we do expect Kappa to be a little bit more.
So, and you see here that the ratio, is quoted here, the ratio, and again, as we discussed during the educational session, this ratio was very pertinent when we digested, and then we say, well, how much Kappa, how much Lambda signal? Is the ratio more than 4:1? Is the ratio less than 1:2? So that's monotypic. But now you can zoom in an area of interest. You know, you no longer, this ratio is probably not as pertinent as before. Anyway, so I think it's polytypic. I don't know if anybody has any comment. I must say, I don't enjoy.
There's nothing in the
There's
chat.
nothing in the chat. I don't enjoy keep track of all these things. I really like Anna here. Cool. Okay. You can keep in the chat. Okay. Number 2. Case number 2. Instead, potentially, this is a monotypic with kappa restriction, which is what most people thought. And case 2 is number 4.
Yeah.
Number 4 is going to be this one. And we look at the H&E. And you would think, oh, that's an easier diagnosis. Look, it's clearly not something that looks like a lymph node with germinal centers. Okay. But still, it could be reactive. You know, it could be still a benign infiltrate. I think you would have more suspicious of these.
Yeah, I didn't see the history for the other, but this is a lesion on upper back of a 63-year-old patient.
You see there is a Graves zone. The infiltrate doesn't really impinges on the epidermis. And this infiltrate has got these intermediate size cells. They look a bit...
They're tiny bit pleomorphic. They look a bit...
Some of them resemble blasts, perhaps. Or these are... Yeah, I think there are maybe, you know, things like that. And it's quite diffuse, this infiltrate, and monotonous. And these cells have a lot of cytoplasm, hence the spacing of the nuclei.
Yeah, there's definitely different forms. Some of them look cleaved, some of them...
Vaguely nodular?
Yeah, it almost looks like it.
And some benign cells at the edge. Some small cells at the edge. Okay. So the...
but they're the size, you would say they're intermediate to large.
Okay, so this one, again, Teresa would say low power diagnosis is all pink. Is already, you know, very...
So it is kappa restricted.
Is kappa restricted. And as we zoom in, obviously you find these more mature-ish lymphoplasmacytic cells that go strong. But you see also the smaller dots. Yeah.
Yeah.
So what if nothing worked here? No silver, because the silver probe didn't work.
Well, we should have also some sort of... I think there were a few cells
at the edge. Yes. Let's have a look at these.
I'm not sure if they're, but I think I've seen a few scattered cells with black signal, like plasma cells at some point. But in any case, I think we do have a
not very
control.
We have the on-slide control indeed. Can point you towards a black signal. Ever.
Oh, there's one there.
Solitary one. Okay.
Maybe that's what it's supposed to... I mean, it's quite monomorphic.
And there are also some dots. And there are also some dots actually here that you can see. But anyway, okay. And yes, you wanted to see the controls. The controls are here. Yeah, the system works.
This patient actually was known to have, we found out subsequently, to be on the follow-up for lymphoma.
And what was the diagnosis?
It was a large B-cell lymphoma. I think we have additional immuno if you'd like. So the morphology can be, yeah, I think we've done some, well, I'm not sure if we have time though.
Okay.
So we've done...
Okay, it's a diffuse large B-cell
because of this nodular pattern, we've also done follicular, you know, or dendritic cells, because they were all negative.
Did we need this Kappa Lambda? Probably not, because there would have been a CD20 positive, 79A positive infiltrate with relatively high Ki67, BCL6 maybe positive or negative. No dendritic cells.
BCL2, BCL6 were positive, so it kind of fits theoretically with the morphology.
So I don't think we would have had a real problem in saying this is a diffuse large B-cell lymphoma. But it's nice to demonstrate kappa monotypic kappa.
I mean,
Okay.
with high grade, obviously, it's much more easier.
Yeah.
So the next one is
some high grade will have much less signal, and it would have been.
But some of them do have the large B cell. Sometimes it's most difficult in CLL cases, and we're trying to stay in a few of those, but not all of them. They do demonstrate signal, but
I think ultimately,
it's less than
we also discussed this during our educational session. Ultimately, if you think the diagnosis is lymphoma, even if you cannot demonstrate monotypic light chain, it doesn't really shy you away from that diagnosis.
Yeah,
you know,
especially in high-grade cases, that can be all sorts of. But I still think even in high-grade cases, if you have like, let's say you have a node with a little bit of involvement, can be useful because that's number 5. Case
number 5, this was a little bit more controversial. Some people thought it was monotypic, but a sizable minority thought it was polytypic. So case 5 is here.
I think it would make sense. Next one.
Another
This
screen.
is very interesting because we have 2 components to this case. So first of all, this infiltrate. I think you did have some like Dutcher bodies, plasma cells, but here maybe the preservation is not great.
Brilliant. Shall we go on?
I think there were some. Most of them are lymphocytic. So you've got this nodular infiltrate that it seems reactive, and you're going to see on Kappa Lambda that
this looks like a germinal center. There are a few mitotic figures here, and these more broader, bigger blast-like cells, and then there may be some polarization with the smaller cells, who knows?
Yeah.
And then these look like much smaller cells or marginal mantle area.
And then there's this in between.
And then in between,
you have these.
Well, you find some larger cells.
Yeah, I think some of this is some sort of intrafollicular as well, with blast scattered along between, small marginal cells, but there is.
Yeah.
If we go to this more diffuse infiltrate, like here, you're right. I think even here you have a few and mixed, let's say, that look more like immunoblasts in between.
And then this is probably similar. There are these pale areas.
Yeah.
Okay, I'm not so sure that the histological diagnosis is that easy. I think you need to throw some immuno here. I think, as you say, I suspect some of these are residual germinal centers from.
But there's this infiltrate between the germinal centers that is a bit suspicious.
So to characterize, we expect this would be B cells, and should we look at this one?
Yeah.
And that's the. So on one side you have a large preponderance of pink.
Yeah, so this had more plasma cells, this section, this piece. And then here, I wasn't very sure that on this section it worked that well, because even in the germinal, you have an adjacent germinal center that it doesn't really show very well. And that here on this piece, I think it worked much better.
This was the area. So you see this infiltrate is quite pink, and then these are those reactive looking follicles, which are more heterotypic, both in the small cells and the large cell population. And these are the marginal mantle areas that you can see cells with both stainings. But this was the population that we were more interested in, no?
Yeah. Here, I don't know if there were a bit more lymphoid.
not so sure. So this is a much more difficult case. I think these are mixed. The plasma cells are mixed.
In these areas,
in these
yes.
areas.
But this area and on the other piece, this shows Kappa predominant for sure in a ratio that is higher than
way above the permissive ratio in this infiltrate here. Okay, so most of these areas are reactive.
Yeah.
But there is this infiltrate in here that is worrisome, and this is the infiltrate on the H&E. So these are acute cells and some cellular debris, and these are slightly atypical looking cells with these.
So we wonder if these are actually, with these pale appearance and plasma cell differentiation, they're marginal cells.
Marginal cells, yes. Do we want to show some other immunohistochemistry?
I think, I'm not sure, we do have more immuno. That's case number 5, isn't it? Not sure which ones we have available. What would you like to see? The problem is,
So you want to show us maybe a CD20 just to paint the pictures at the moment? Okay. So and especially in these areas here. Okay.
I think, could this be because of the many plasma cells?
Yeah. Not so
And
good.
the other area
And the
was
other area
this.
was there in between.
I think it shows similar kind of expression, plus the B cell areas in the follicles.
Do you want to show us CD 21 or CD23?
I do have a CD23. I have both of them.
Okay, so just to show that you have this scatter of cells of spinning out of the dendritic cells of the follicles. There. So there is this expansion. And 21, I think, was next door to it.
Yeah. So this is much cleaner because you have not as much lymphocytes staining with CD21.
And then do we want to show maybe a Ki67?
I hope I have it. I'm not sure it's been done, to be fair, in this case.
What have we got?
Was it? So these cells were only staining with MOM1 from what I could see when I was reviewing this case, I think. So it's a bit confusing because do you think these two populations are related necessarily, or because the reactive tissue is so striking and then you have all of a sudden this population of, so this is MOM1. And I think that's the only, I don't expect it. Maybe BCL2 would be positive because we expect that
in this context, BCL2 is not really very useful.
It's not. And BCL6 should be negative really.
Not a good section.
But in any case, it should be positive.
So,
I mean, I think it's got to be.
I don't know what diagnosis we made at the end.
So this was our dermatopathologist colleague who thought, I think rightly so, that this could be a marginal zone lymphoma. But he wasn't sure it's actually primary because of the morphology, but I guess because we have all that reactive tissue around it.
I mean, after looking all this, I remain a little bit uncertain on what is the target of my attentions, but certainly there is a monotypic
Well, this is the problem, because if there are, I mean, you would expect in normal to have this expression in plasma cells, but in atypical or lymphoma cells, you can have even higher expression. So this could also be some sort of, you know, additional argument, because we don't see as many plasma cells as we thought they would be, because the expression is so high.
Yeah. But these areas are the areas that are odd. So while this could be a reactive infiltrate, this one is a more monotypic infiltrate, which kind of links up with the observations on H&E, that these cells are atypical, intermediate size, and they have this monotypic expression. They are B cells and they are monotypic. So that raised the stake and pushes towards suggesting this could be.
It's also strange, this high expression, which would be, I mean, there is a discrepancy between the fact that we see lymphoid cells, right? And you have this.
And you said this lady or this patient, I don't know, had a history of.
No, he didn't have, but it's one of the few patients that they thought it was lymphoma in the skin
by the
clinician.
Okay. So, and I don't know what happened, because then we would have sent this for review for a lymphoreticular MDT.
Yeah, probably she was discussed. But if this was an isolated lesion on the skin, they've even excised it. So their impression was lymphoma. They want to take it out because they thought it was an isolated lesion.
Okay. So I think, in my opinion, this case is quite difficult. Again, maybe you would have sent this case out for review to a lymphoreticular pathologist without all these other investigations, but maybe the availability of Kappa Lambda makes you more inclined to provide a provisional diagnosis of lymphoma, cutaneous lymphoma, B cells.
Yeah, you need at least to raise the suspicion and be more flag it up for the MDT, basically.
Okay. Case 4. Case 4 seems to be polytypic for many participants and for the panel. The case 4 is number 6. Number 6 would be this one.
Yeah.
Jenny. Another skin punch biopsy. Very dense infiltrate.
Yeah, it seems to have plasma cell differentiation. There are plasma cells.
Yeah, they're definitely mature looking plasma cells. And then there are these small lymphocytic elements. And then whenever you start looking in detail, you can convince yourself they are abnormal. The nuclei are a bit irregular, angulated, and slightly atypical.
Yeah, I think there was a worry for sort of hyperplasia.
It's not really involving the epidermis. We know these were B cells, I guess, because must have done some immuno. Here you see what Adelina was saying, a large number of plasma cells. They seem mature plasma cells.
Yeah, some of them are reactive with 3. One of them had 3 nuclei. So we sometimes see that but if the tissue is highly reactive, it's normal to see that.
So, and what about down here?
Well, I think it looks the same, but
this is a pulse section. This is what happened. This is a punch biopsy of skin. Nobody really cared about processing and cutting for lymphoreticular assessment. Therefore, you can see the cytoplasm is homogenized. We can't see inside the nuclei. It was probably processed as you would process a skin, so relatively short processing. So not ideal. Let's see if this one is any better. Maybe slightly more open nuclei that you can see into. Okay, so suspicion is that this is a benign infiltrate. And let's see what Teresa say at low power. I think you see both colors here, yeah?
Yeah.
Definitely. So certainly the large cells, or the strong staining cells, sorry, are polytypic.
Yeah, which are the plus. I think someone did a spirochete stain as well for this.
Because there are too many plasma cells.
The plasma cells. Some of them were around the vessels. And
okay, but in general, this will not be a case where you feel suspicious and you want to do Kappa Lambda. I mean, I know somebody did it, but you know, not particularly important in this particular area. Yeah? Polytypic.
Okay, if you say so.
Well, well, you know what we always say? We always say it's a new stain unless you start using it for all the cases you know the answer of. Then,
Yeah.
and you only use it for the difficult cases, then you will never be able to interpret the difficult cases.
And I think we're all wary of that, I guess.
Okay, so case M5.
It was, yeah, that one had the significant proportion of monotypic as well,
yeah.
even the previous one. So if you have comments or any questions,
oh yeah, please do let us know. And given that I'm not very good with the Zoom, maybe you should unmute yourself and speak if I don't pay attention to your comments on the chat. Okay, so case 5 is 7.
yes.
They're all skins. At low power, this is slightly more worrying. It's effaced. This is like a vague nodularity, but not very good.
It does have some sort of nodularity. And the worry here is that high...
I don't like these cells.
The cells are they're mixed in places with smaller...
Yes, there is you can see at this power, small lymphoid cells, and then these larger, paler.
Precisely,
cells.
but the cells look very ugly.
Let's see if we can find an area that is better stained, better, yes, and quite ugly. So this is lymphoma. I promptly forgot what was in the PowerPoint slide. This looks very worrying. Oh, Hannah is joining us. Savior, very good. I would say I'm worried about lymphoma here. And this,
100%. We've had some more immuno. I think we should have more immuno.
Do you want to look at more immuno? Yeah, whereabouts? Yeah.
Case 7. So quite a bit of immunostains.
What
would you like to see?
Let's do a CD20 or CD3.
So because it's a bit nodular, I think we have key 67, but we keep that for the end. Let's look at CD21, 23.
Okay, yeah, 21, 23 to see if there are dendritic cells. And there's been an expansion of reticular dendritic cells. You can see here very untidy expansion.
Yeah.
Here they are. So, and 23,
you're in the right place.
Yeah. And interestingly, the expansion has got more of one
dendritic
type than the other. And I've kind of never read these things in books, but talking to good hematopathologists, they always say
this is a
lymphoma. This happens in lymphoma more often than in benign.
Yeah, so with CD23, we see mostly the lymphocytic cells at the periphery of the nodules or in between.
Yes, rather than dendritic cells, spiky things. So what else have we got here? What's this? 20? 20. Well, 20 would be good to see. This is the thing. It's essentially all 20. Let's see if we can recognize also the cells. And it's good also because it shows the size of these cells, quite intermediate.
They're pretty large cells.
Yeah. And then what else we got? 10. CD10, that is really useful in lymph node. I find it much less useful in skin. Because
it's
the follicular lymphoma in skin is not really, often is not CD10 positive.
But we do
what
have
is
some
this?
wishy-washy staining in the neoplastic cells, but it's mostly in the stromal cells around the nodule.
Yes, because we know CD10 stains
But
the.
I thought we did have a little bit. Well, CD10 is not the best stain on this.
Not
But,
the
you know, these cells can express a tiny bit, sorry.
Yeah. There is a little bit of expression. Some of it is cytoplasm, some of it is membrane. I think most of it looks like aberrant expression, not localized to the membrane, as you can see here, and is inconsistent. It's not very sharp. So just as a reference, look at how the CD10 stains in your controls. You see that's the kind of signal you should get. And then, of course, in skin, CD10 stains all the spindle cell, all the fibroblasts. So that's also what you're seeing at the edges.
But it's interesting that is around the lobes.
And then what have we got here? BCL2. Why not? Because we saw that there were follicles. Yeah. And there are large areas of BCL2 negative. So this could be reactive expansion. Yeah,
reactive or high grade enough.
High grade that they
so it doesn't show it.
Yeah. BCL6.
Yeah. So BCL6 does stain.
Okay.
But that doesn't, it's not really specific, is it, for follicular, if that's what we're thinking. CD5, there were quite a few
cells,
I think.
Okay, so we have an expansion of 20 positive large cell, 20 positive, 6 BCL6 positive, BCL2 negative, which
MUM1 was negative.
MUM1 negative, BCL2
but this
negative, which is
this
also
is K67.
and K67 is wall to wall. Definitely.
So we have a little bit of
this is a diffuse large B-cell lymphoma.
So this is what we
post-germinal center, maybe.
This is what we are kind of suggesting, that is a bit too high grade for it to be follicular because it expresses.
And the Kappa Lambda.
That's MUM. No, we need to go to the other folder.
We need to go to the other folder.
Well, MUM1 was weak, but
which one is it? I can
it's
see
number
this one.
7. Next one.
Yeah. Okay, so we don't really need Kappa Lambda now. Why did we do Kappa Lambda? Because we like to play. But again, in order to interpret this thing, these are all black.
Yeah,
you know?
But again, it's because we have such a high.
The big cells are staining, and some of them stain. They have a lot. Yeah.
Yeah, that's why I'm saying in high grade cells, we see a lot of this because we've been doing it also to get used to it. And I would say it's a bit suboptimal, the staining.
Didn't work very well.
Yeah. And
that's the problem with immunohistochemistry, with in situ hybridization. You need to smell the areas where the signal is absent because something has gone wrong.
But also, I didn't show you CD5 very well, but there were so many T cells.
T cells
around those very typical.
You mean here?
Yeah, I think so. The way I recall is here.
Yep. These are small T cells.
But also at the periphery of these atypical areas, there's a lot of.
But these are also CD3 positive. We should we have a CD3.
Have it.
BCL2, BCL6.
It's not copied.
Not copied.
No copied.
Okay.
But there were lots of BCL.
but there will be also 5.
Because in the neoplastic cells they were negative.
Okay. Cool. Okay, so monotypic silver enhancement, which is lambda.
Yes. Not 100% very optimal because also we see plasma cells.
This area, this side of the biopsy didn't really work very well.
And I think this is the second section.
Do we have
there are 2.
Okay.
Yeah, so this one was a bit better in this area.
Okay.
We do have a few cells with kappa.
Does it matter?
Well, just to think that it worked. on the tissue
Not very
section.
important. I think this is quite common. This is a very kind of easy.
Yeah,
easy to interpret.
we should never forget that there are reactive changes that can look very bad with irregular germinal centers and all sorts of gray cells.
So the last case, again, I think most people thought this was a monotypic Kappa arrangement. Pink, Kappa pink. Yeah. So it's case number 8. This one
This
here.
was actually a breast lesion.
Breast lesion, core biopsy, lymph node. Can I put it?
It's a breast lesion that you reported.
Okay.
So maybe you remember.
Maybe. So, you know, breast is biopsy because there is a large lymph node. They're investigating breast cancer. They want to know if there is metastasis or not. And it's negative for metastasis. But so there are these hyalinized areas that I'm not too fond of. But there are these small to medium-sized cells. They're a bit monotonous, a bit ungulated. And you don't really, I mean, maybe this one could be a normal architecture, but you don't really recognize normal architecture node. And then
I think there's a bit of residual.
Maybe a residual. And then it spills over the capsule, which is also a worrying feature if this is the capsule. So
I'm not even sure it was a node to begin with.
It might not have been a node, yes. Okay, so number 8.
Go to immune.
Let's go here. I don't know what this is.
BCL2 or CD20, which
CD20, yeah. CD20. Okay, CD20. There's some area not
This is exactly the area you pointed out. Like that was a different structure.
This could have been a native lymphoid structure.
Infiltrate.
Yeah. But all the other is well, this is cooked. No worries. But this area here, and you see the angulation of these cells. They're not really nicely round. Okay, so this is 20, and then as a comparison, 5 because we don't have 3. I like 3.
I hope it was.
Okay, so that's a T cell area probably, and these are B cell area. This will be an infiltrate of T cells most likely.
Yes.
Yeah. Okay.
Yes.
And then what have we got? 10, I guess. Yeah. CD10 should show us whether there are residual follicles, but nothing.
Which not really. Maybe that fragment up there.
Yeah, but I didn't really want to look at it because it's a bit, I don't know.
Because it had.
But this bit here, this is the worrisome thing. But so this area here, which was the one reaching T cell, doesn't really have CD10 positive cells, and this is our expansion. You know, that mostly these cells are negative, and then what else have we got?
We've got BCL6, BCL2.
Let's see 6. And let's put it upright. So this was our area. Not really anything.
In the normal.
This could be a reactive.
Yeah, the residual structure.
And then this is BCL2. I don't think we will learn very much about this. It's BCL2 positive, but I don't know. And then you said we have Ki67,
which low.
Is low. This was the area I was most worried about, this infiltrate. Okay. I don't think we have a good complement of immunostaining so far, but
what would you else would you added? I try to.
Yes. So these cells are 5 negative.
Yeah. They're negative for everything.
For everything. Okay.
BCL2, of course.
So what is your differential diagnosis here if you are fearing a small B-cell lymphoma? Could still be CLL, although 5 is negative.
Yeah.
Could still be.
I think I just put the minimum through. CD23 was negative as
marginal, mantle.
marginal.
So cyclin D1, IgD, for instance, we wouldn't need to understand what immunoglobulin expression there is in this tissue.
I mean, obviously marginal is because if it's negative for everything, all the...
What happened here in this area?
Well, let's go closer because maybe there's...
I think something has gone wrong with the process.
That's also that area that we said it stains with other things. So
this is the CD3 positive area, but it looks as if we did not.
Is that area of? Can you put the CD5 next to it?
I will do that immediately.
Maybe there weren't that many though.
If you point me towards the CD5, this one. Very good. And I think it's upside down.
Yeah.
For the sake of everybody. Okay. So maybe this is not an artifact. Maybe this is the fact that these are T cells.
It's hugely T cell.
No signal.
Probably T cell area mostly.
Okay. Happy with that. And then there are these expansions.
There are few, but I think they're also, I'm not sure if they're on the cytoplasm or nuclear.
These bigger blobs. Is this CLL?
Let's check another area. This seems less so.
So I think overall there is a lot of magenta signal even in the small cells and the big cells. There are these clusters of black dots associated with the magenta. Can this be IGLL5?
Yeah, I think it, I mean, in some cells, I can see it over the nucleus, like there, where you were here, for instance. But I'm not sure.
They're quite coarse granules.
The other thing is, can it be non-specific?
Or can it be non-specific?
But I felt like there were oftentimes over the nucleus, so maybe we shouldn't even, but even if we count those in, it would still be a predominant.
Yeah. Do we have another section here, or is it just a single section? Not
I
really.
think it's just that one.
What I find, my comment about this particular slide is, as you can see here, I don't think this is the scanning. I think it's quite a thick section, so you don't see the borders between cells.
The other thing is,
and so I would have done it on a thinner section, cut the thinner section to do these stainings.
The other thing is, I think you're right with the thinner section, also because it helps us to see better the signals outside the cell. We had a few cases that show signals outside the cells, and initially we interpreted as polytypic, and then when we spoken to Teresa, she said, but
they're actually outside the cell.
Actually outside.
Yes. So it's a precipitate rather than a true in situ hybridization signal. So I think when you look at low power, you have this overwhelming impression of pinkness. So monotypic. But then when you go at high power, you find that there are also black dots. Although a lot of these black dots are associated with in the cytoplasm of these cells as a big clusters that may be IgGL5 cross reactivity signal. We don't find any in the nucleus, do we? Or we don't know. That's the problem. Is this slide is not very good at telling us where these dots are.
Some of them are over the nucleus, the larger.
Should we see if there is a better?
A little bit, we are starting to approach the end of the hour, so I thought maybe the last minutes, if we have questions from the audience, we could address those.
Yeah.
Yeah.
And there was one already submitted in the platform that asked, how can we ensure the quality of the assay? So what quality do you do?
With on-slide controls or with the quality? Yes. So the discussion about the quality is, I think you need to use this assay more in your diagnostic routine so that you are always checking on known cases where there is an obvious lymphoma that you can demonstrate the monotypic or vice versa. So that would be something. And then we spoke about the on-slide controls, and we had a little hint about the fact that whenever you're dealing with lymphoid infiltrates, your fixation and your processing needs to be for lymphoid tissue, not for skins or whatever it is that you're processing, and cutting sections. I mean, I remember Professor Isaacson always had a small piece of lymph node embedded in resin, because resin you can cut is the embedding in resin is for electron microscopy, but he wanted to cut thin sections and stain with H&E in order to get a much better morphology. So thin sections are very important. And here in the lab, we cut up 1 micron whenever we have we have another H&E cut thin, and that's kind of revealing. And I think you should think about using the same thickness for your immunohistochemistry and in situ hybridization, to be honest with you. What do you think, Emilia?
No, I think, but that's also one of the problems, especially dealing with extranodal lymphoid infiltrates. You're not really aware about them until you see them under the microscope. So then it's kind of a momentum 22. You need to start from the scratch with thin sections, and pre-analytics is already done. In addition, RNA is prone to degradation. So there is also, you can use the U6 probe just to check for the RNA integrity. Because it might very well be the tissue and not the assay. But on-slide controls for me is also very important, just to check that you see the signals. And as you say, just learning how these different intensity levels, what they really mean, because if we used to IHC and we only see plasma cells normally, and suddenly we have the full spectrum of all the B cells.
Yeah. And while most diagnoses are probably relatively simple, and the more immunohistochemistry or additional stains you do, just add, and people say, well, why are you doing this? It's because, we reinforce the diagnosis because a lot of these elements fall into place, and we can say, well, the whole thing is consistent with something. And maybe you could have arrived to it with 3 immunostainings. But then perhaps you will be more approximate in other diagnoses, which, not as robust. I don't know.
And
I also just needed to say you were very welcome to stay, but I need to drop off. So I would like to just take the opportunity to thank you so very much for this session.
Thank you, Emilia, and thank you, everybody.
Thank you.